Hello everyone, today we're back with a short review on breast pathology. In front of me is a fibroadenoma. These are the most common solid benign breast masses, and often we see these in younger women, so usually between the ages of 20 to 35 years old. You can see them in older women, and if you do, they're often associated either with hormonal use or sometimes associated as well as with obesity because of the increased estrogen. When we do see them in men, two things that we need to think about. The first being, are they taking hormones for some reason, or is this really a case of gynecomastia? Gynecomastia is a separate entity, so we won't be covering that today. One of the other things that you really should pay attention to with fibroadenomas is that there's an increased incidence of them in Asian women, and there's no really known reason for this. So if someone out there has a project that looks into this and figures out maybe some correlation, that would be very interesting to a lot of people. One of the other things that you should think about when you see fibroadenomas, particularly myxoid fibroadenomas, is the association with Carney complex, not Carney triad, Carney complex. In about 20% of patients with Carney complex, they will have breast myxomas or myxoid fibroadenomas, and these can be bilateral. So make sure that you understand the correlation there. Fibroadenomas themselves are generally painless mobile masses, okay? So patients aren't going to come in, they'll come into the clinician saying, oh, I feel this lump in my breast, and I'm not sure what it is. They may or may not feel lobular, and they can hyalinize or calcify over time. So they can go from being like, oh, well, I have this relatively soft mass to I have this very hard mass. So you can definitely appreciate why we would want imaging on these, why we would want biopsies on these. And because they are hormone receptive, they do fluctuate with cycles. So often in the history, you'll get something where they'll say, oh, I notice this lump comes around when I'm close to my period, and then it'll go away, or something like that. On imaging, because these have relatively characteristic imaging, they generally will describe well circumscribed, so either ovoid or round mass, and they're generally hypoechoic and homogeneous. When they do their elastography, they will be soft, and they generally don't have increased internal vascularity. And that's important because when we think of invasive cancers, they're usually irregular, spiculated, hard, they have increased vascularity. So those are things that you want to keep in mind. And so just reviewing the imaging before you even see your slides can really tell you what way you want to go. Grossly, these are going to be very similar to their symptomatology. They're well circumscribed, they may or may not be lobular, and they may or may not have calcifications. And if they do have calcifications, remember we get that gritty sensation when you're cutting into them, okay? They're generally tan pink to tan white, depending on are they fresher, more hyalinized, are they calcified, and they have this firm, rubbery, like eraser-like consistency. So when you're thinking fibroadenomas, it's basically synonymous with your leiomyomata in the uterus. Okay, so let's get into the micro. So generally, and we're starting at 2x here, these are well-circumscribed masses. So if I go to the edge of this, and this is one of the larger sections, you can see that it is generally well-formed, it's round, and it has what is called this pushing border. And a pushing border means that as the tumor expands, as it gets larger, it's just shoving the other tissue out of the way. It's not infiltrative, it's not trying to take over the areas occupied by the other cells, but we have a pushing border. And you get the sense that these are relatively pink tumors, right? We have some glands in there, but it's generally a sea of pink, okay? And fibroadenomas are biphasic. So first, if we look at the stroma, which is all the pink areas, what we see generally, even at low power, and with these you always want to kind of look at low power first, is that there's not a lot of cells. It's relatively hypocellular, it's somewhat loose, and nothing is overtly scary looking at 4x. If I switch us up to 10x and get in focus, what we start to appreciate is that these cells are very monotonous, they're very bland. There's like no pleomorphism, no crazy looking nuclei going on here. And that's exactly what we want. Now, things that you can see in the stroma in these lesions, and we'll see if we can find an area. This doesn't show it too well, but sorry, just trying to get that gland into the center. Okay, it doesn't want to go into the center. That's as good as we're going to get. So what we notice here is that the stroma kind of forms this cuff, or kind of loops around that central gland, okay? And this is what you want to see, is that it really should be perpendicular to the orientation of the glands. Often these are perpendicular to the basement membrane. I don't think that's necessarily too easy to appreciate in this, since our basement membrane is running essentially parallel with the fibers in a lot of these areas, but that's something that you can see. I think the cuffing maybe is a little easier to appreciate, where it's, again, just kind of going around those glands. You can search through this entire case, all 8-10 slides of it, however much is in there, and what you won't find really, though, is mitotic activity within the stroma. Okay, and that's something to keep in mind. That's very important, because that helps you with your differential. If you do find an occasional mitotic figure, that's okay. That doesn't make this not a fibroadenoma, but the mitotic activity should be very low even if you do see mitotic figures. Extremely rare to find in stroma of these would be bizarre giant cells. And bizarre giant cells just means like the nuclei within it are very irregular. They're not round. It doesn't just look like there's a whole pile of nuclei within a cell. They just have this very funny look, and often very eccentrically placed irregular nuclei. Something else that you can rarely see in fibroadenomas is heterologous elements. And heterologous elements are normal tissues that are present in an abnormal place. So what does that mean? In a fibroadenoma, that might mean that maybe you have some cartilage formation, some bone formation. You can occasionally see things like muscle, but we do have muscle in the breast normally, right? So this may be... Let's zoom in here, and we'll zoom in and we'll get in focus. This maybe shows the cuffing a little better. You can see the more dense pink cuffing around that gland. Okay, but those are things that you should think about. Some other things, and I will show you this in some of the later slides, is that you can often have this myxoid change. So what that means is that your stroma is going to appear a little looser, a little more gray-bluish, and that often is seen in younger patients or newer lesions, whereas the hyalinized stroma, and hyalinized just means like a dense collagen deposition, and that's also when you would think about calcifications. These you tend to see in older lesions or older patients. So those are things to think about. This, I'm going to show you, this has more of a myxoid type background. We're not seeing that right now. Right now we're just seeing standard fibroadenoma, but I do have some of that to show you. If we move on to the epithelial component or the glandular component, this is a pretty good area to show you that. So what we have with it is you either have cuboidal or columnar epithelium. And maybe if I go to this little gland up here. So the little gland that I now have centered, this I think shows it a little better. We have very bland columnar epithelium. Now, even though it's bland, in the breast, you don't want everybody to look exactly the same. So you notice that there's some slight variations in size, in shape, but they generally look like, hey, they all belong within the columnar epithelial family. And what's really nice about this gland is that you can really appreciate that secondary level that's underneath the columnar epithelium, and this is your myoepithelium. So what you notice with myoepithelium, if we zoom in even higher to 20x, okay, is that sometimes they have these vacuoles within them, so hopefully you can appreciate that. And they're always immediately underneath your epithelium, okay? So when we talk about in situ components versus invasive components, the in situ means that it has that intact myoepithelial layer. So that's what you're looking for when we're talking about things like DCIS or LCIS, okay? Some things that you can also see in this, associated with fibroadenomas is sclerosing adenosis. You can see apocrine metaplasia. You can see squamous metaplasia. And you can also see UDH, or usual ductal hyperplasia. What this case has, that's a little interesting, and some of you might have seen it as I was driving around. We'll go back to a good place. Is that it has a bit of a papillary component. So this particular fibroadenoma has some components. So there's one, some features suggestive of involvement by papilloma. There's no atypia in this papilloma, so if you left it at fibroadenoma, that would be okay, since it's completely excised. Okay? So that's our general gist of things. Rare things for you to see in fibroadenoma. I'm going to show you some of the other areas. So things like this. So what you might notice is that the stroma here looks a little paler. So this is more of that myxoid type change, and this brings into question like our different patterns. So on the first slide, we had very open glands, and that was more of a pericanalicular pattern, which that's kind of the appearance, is that it looks more glandular, versus this, which the glands look very slit-like. They're kind of squished together. You could argue that maybe this is looking a little leaf-like, and this is more of the intracanalicular pattern. Okay, so the patterns, even though we have two distinct patterns that we see with fibroadenoma, those don't have to be mentioned. Okay, so you don't have to say fibroadenoma pericanalicular pattern, because that's strictly academic for us. It doesn't mean anything clinically, but this is just more or less for you to appreciate that there are two different patterns, and it kind of helps you realize why we have the differential that we do. Going back to very rare things that you can see, less than 0.5%, so less than 0.5% of fibroadenomas will be involved by some sort of carcinoma. So whether that's your ADH, DCIS, lobular neoplasia, or just overt invasive ductal carcinoma. The in situ component will be a little more common, but overt invasive carcinoma involving a fibroadenoma is extremely rare. What's more common is that it's adjacent to the fibroadenoma, and the fibroadenoma was just kind of like an unwilling participant. But that's extremely rare. So while I said you don't have to mention our patterns, okay, things that you do have to mention is stromal mitotic figures, as well as stromal overgrowth. And the reason you have to mention these things is because the highest thing on your differential is going to be phylloides tumor, okay? So things that make you think phylloides, and this view might make you think, is this phylloides? But no, this is not phylloides for a couple of reasons. The most prominent being it's not cellular enough, and there is no cambrium layer underneath the myoepithelial layer, which is like a condensation of cells. So it's more hypercellular immediately underneath the myoepithelial layer. So even at low power, this would tell you go against phylloides. But that's what I wanted to show you on this, because this just had that really nice intercanalicular pattern. And here you see pericanalicular. So these are often mixed. They don't have to be pure for one pattern or the other, and the pattern doesn't really matter. Of course, there's variants, and you should mention those. Like if it's a myxoid fibroadenoma, okay, well, that may or may not be important. It's particularly important if the patient has a history of carne complex and cellular fibroadenoma, because in your differential would be benign phylloides. And I'm going to go 2x and get in focus, because I think this slide really shows the best that myxoid change. So you can see, hopefully, the stark contrast between those pale gray-blue areas and that pink, more homogeneous, hyalinized stroma that we're used to. Generally, you don't have to stain fibroadenomas. This case was not stained, but if you wanted to, your epithelium generally will stain with estrogen, so ER, CK7, EMA, and other keratins, like if you want to do A13 or CAM 5.2, those should be positive in your epithelium. In your stroma, you often have scattered staining of ER and PR, CD34, beta-catenin, and remember, if you were seeing mitotic activity and you threw a Ki67 on this, it should be low. And what low means for fibroadenoma is less than 5%. I guess we'll just go back to high power so you guys can maybe see those layers a little more. So here again, so this maybe looks a little more cuboidal here, but you can see we have that relatively bland epithelium, and then immediately underneath you have the myoepithelium with those vacuoles. Okay, so it really stands out. This is such a nice case for this. Other stains, well, variable, so whether or not you want to do them would be like smooth muscle myosin heavy chains, or SMMHC, smooth muscle actin or specific muscle actin, SMA, P63, and other myoepithelial markers. Most of those are markers that you'd use for myoepithelium. And remember, you don't have to have diffuse staining of myoepithelium for it to be there. It can appear relatively focal as and still be considered intact. Okay, you remember, we're seeing a snapshot on a slide, so everything's in 3D, so it might not be within the exact plane that you're looking at. For molecular, you do not have to do molecular for diagnosis of fibroadenoma. Most of these will either be monoclonal or polyclonal. Something to note, though, is that your epithelium is always polyclonal in fibroadenoma. And why is that important? Because when we think of clonal processes, that's when we start thinking that, okay, there's something abnormal going on here. But in fibroadenoma, your epithelium is polyclonal. There's several mutations that they can harbor, though, and one of them is the mediator complex subunit, or MED12, and that's on chromosome X, Q13, and that's seen in about 2/3 of cases. What's important, though, is that if you were considering, is this carne complex? Is this a myxoid fibroadenoma associated with all that? They will not have MED12, okay? Myxoid fibroadenomas do not have MED12 mutations. And why is MED12 important? Well, that affects estrogen signaling. Okay, so again, remember, these are hormonally receptive tumors. They affect the extracellular matrix organization. And something to keep in mind is that you'll also see these MED12 mutations in uterine leiomyomas. So we talked about earlier how they grossly look like them, but they also tend to have like the same mutation. Other things that have been described in the literature include things like TERT promoters or RARA mutations, but again, you don't have to do mutations to diagnose fibroadenomas, but just know that they are there. For your differential, phylloides is always going to be at the top of the list, okay? And again, even in this view where it still, like, maybe it looks a little more leaf-like, okay, these broad leaf-like areas, there is no cambium layer, there is no increased mitotic activity within the stroma, and the stroma is relatively hypocellular in this case. If you had a cellular fibroadenoma, a good thing to pair with that would be low-grade phylloides, okay? and looking at the differential. So obviously, if all you had was a core needle biopsy, you wouldn't want to make that distinction between fibroadenoma and phylloides. But when you have an excision specimen, that's when you can really tell what's going on. Other things to think about would be a fibroadenolipoma, which is a hamartoma within the breast. We can have things like fibroadenomatous change, which sounds a little bit like a misnomer, but fibroadenomatous change means we have things that look like fibroadenoma. So you have glandular and stromal components that look like fibroadenoma, but there's no actual mass lesion. Okay, so that's fibroadenomatous change when we say that. You can also think about pseudostromal angiomatous hyperplasia, stromal hyperplasia, or PASH, tubular adenomas within the breast, as well as fibrous tumors. But really, phylloides, fibroadenomatous change, those are your big hits for your differential with these cases. For treatment, if they're small and they don't really bother the patient and they don't look suspicious on imaging, they often just observe them. Okay, there's no need to excise them if they don't have to, but they can excise them. Okay, and these are benign lesions. However, they do confer increased risk. So you're looking at anywhere from 1.5 to 2 times relative risk, or 5 to 7% lifetime risk of developing invasive carcinoma. Okay, so these are a tumor, but they're a benign tumor. So there is an associated increased risk of invasive tumor at some point in the patient's life. But again, these are the most common lesion that you will see. And I just thought this was an absolutely beautiful case to show you. There's a little more of what we saw earlier, our pericanalicular pattern with a little more of the myxoid stroma around it. Like, that is just lovely. But that's what I have for you. This is fibroadenoma. So if you like this video, please hit like. If you aren't subscribed already, please hit subscribe so that you're notified when we have new videos coming up. If you have comments about this video, things I missed, things that were confusing, please let me know in the comments or send me a message on Twitter. We have our Twitter handles below so that you can reach us easily. And if you have suggestions for things that you'd like to see covered, I'm happy to hear any and all suggestions, and I do try to get cases where I can. And that's what we have for you. So thank you for sticking around, and we'll see you at the next short review.